So we've heard about diagnosis, and now we're going to jump to therapeutic considerations. And that will be Dr. Gordon Brumbaugh from the University of Idaho. He'll be telling us, will antimicrobial resistance of BRD pathogens impact BRD management in the future? So Gordon Brumbaugh is the director of the Kane Veterinary Teaching Center in Caldwell, Idaho, that is part of the Animal and Veterinary Science Department, College of Animal and Life Sciences, University of Idaho. He earned a DVM from Kansas State University, a PhD from the University of Illinois, and is a diplomate of the American College of Veterinary Internal Medicine, large animal, and a diplomate in the American College of Veterinary Clinical Pharmacology. His experience includes large animal clinical practice in private and university practices, pharmaceutical industry experience, international consultation, international teaching of professional veterinary students and postgraduate students, and research in several areas of large animal internal medicine and veterinary clinical pharmacology. Dr. Brumbaugh?
Thank you very much, Dr. Carroll. And thank you. Dr. Grodelushian called me a little over a year ago and asked me to do this, and he caught me in a moment of weakness. I said yes, but I justified it later after I got off the phone thinking he'd forget, but he didn't. So I need your help in trying to answer this title. Will antimicrobial resistance of BRD pathogens impact management of BRD in the future? How many of you today or in this last year have used antimicrobial susceptibility or antibiograms to determine what kind of treatment protocols you might apply? Raise your hands if you do that. Okay, several people acknowledge that, so we answered the question. Can I sit down now? Or shall I force them to look at the rest of the slides? The answer is yes, it has, it does, and it will. My concern is more about how will it impact decisions in the future. I want to warn you, the following could be controversial. I know this is a very sensitive audience, so if you need to take action to divert yourself, go ahead. Doesn't bother me. I'm like Baxter Black. If you get up and leave, it doesn't bother me. It's when you get up and come towards me. So please do as you'd like. There may be something in here that insults someone. I read or saw a book about John Wayne here a while back, and he said as he was growing up, his daddy taught him never to insult anyone unintentionally. So if you do not feel like you're unintentionally insulted in the next half hour, realize it's totally unintentional. We live in a day and time when Dr. Google might be nominated as Consultant of the Year. CDC's putting out notices that cause fear, create some anxiety across the public. We need to realize fear doesn't stop death, it stops life. And I think when it comes to this subject of resistance, we need to stop being afraid, take the bull by the horns, and do something about it. Anytime there's more than one pair of eyes looking at something, we get different perspectives. And so I'd like you to look at this picture a little bit. Contrary to popular belief, this is not Dr. Knopfsinger at one of his cattle handling clinics. Okay, so as you look at that, you've got an idea of what's going on at the time that picture was taken, right? All right. What this is, this gentleman back here on the tail, he was out minding his own business, pushing his bull down the road. He lost control. The bull ran up on the sidewalk, ran into this innocent bystander, and then they got back out in the street where this picture was taken. They went on down the road, knocking plants and everything all off the sides of the road. How many of you came to that conclusion? Okay, I've been told I'm weird and I don't look at things the way other people do. I don't see it that way, but just for the sake of conversation, we'll go with what you're thinking. Which of those two individuals do you think is going to influence the next thing that bull does? Going to be the guy hanging just inches away from his eye, or the dude white knuckling his tail? My vote's for the guy up front. I think science would prove, if we had research, that the tail end generally follows the head end, right? So the guy up front's probably pretty darn influential right now. He's taking that responsibility serious. You can imagine the stress he's under, changes in neurotransmitters, all those things we just heard about this morning. After that initial catecholamine surge declines, I'll bet he'd be willing and primed to talk about pole genetics, but right now he's not thinking about that. I think the bull represents resistance, antimicrobial resistance. I think the guy hanging on the tail represents most of the activity that's going on globally around antimicrobial resistance. There's not very many people taking the responsibility to grab the bull by the horns, the risk, and really be influential in changing what's happening. If I could speak to these two at this time, I'd tell the guy up front, I said, man, I admire your courage. Might question your judgment, but hang on, you got him right where you want him. I'm going to go get you some help. If I was talking to the guy at the back, I'd tell him, stop pushing. The golden age of antibiotics started when penicillin was discovered. There wasn't commercial preparation sufficient for commercial use until 1950 or thereabouts. So I want to ask you, when did concern about resistance arrive? Before penicillin was commercially available, in an interview with the New York Times, Fleming told people, bacteria are going to change. When did resistance become concern? There was a study done, it was published in 1958, but in 1951, a record was kept of the sensitivity to available antibiotics of most common bacterial pathogens. Concern over resistance is not new. In fact, Robert Miller published this digital photograph a few years ago. Caption says, I suggest you rotate your chance. If you use the same one all the time, the demons may develop resistance to it. I think it goes back hundreds of years. I've heard that antimicrobial drugs are the only pharmaceutical products that cure disease. How many veterinarians are there here today? Raise your hand. Maybe I'll do it the other way. Who is not a veterinarian? Okay, well, you don't need to know this. You probably already understand this. You're probably order buyers. You already know this stuff. Veterinarians, we had to go to school. In pathology class, we learned about cure or healing. We're in a healing profession. 4 steps to cure or healing. Actually, in the newer text, they divide one of these. I don't know which it is, but the 4 is easy enough to go through. First step, to kill or inhibit the offending organism. The second is clean up the damaged tissue, repair or place that damaged tissue, and return that tissue to function. Without those 4 things, there is no such thing as cure. Antimicrobials cure, right? So what's the job of the antimicrobial in those 4 steps? The only step an antimicrobial drug can participate is the first one. And it doesn't do that by itself. It's an important step, but the animal's got to be involved. The rest of them are the job of the animal. But if we don't get the results we expect, what gets the blame? It's okay, you can say it. The drug and the veterinarian that sold it to me. How do we measure the performance of that drug when it only participates in one part of cure or healing? And while you're thinking about that, if you really think that's the best way to do it, go home, tell your boss you want to be evaluated the way we evaluate antibiotics. See if your performance evaluation changes. We live in a day and time where the last few years have been decreased production, development of antimicrobials in people for human use as well as for animals. We are in a growing era of compliance guidelines, regulations. And this is one of the later ones that many of you are familiar with. We've got 3 years to implement this voluntary alignment of labels with use of products. Nowhere in that guideline can I read that they say what's going to be measured or when. What I want to talk about is what is resistance, what isn't it? Do we have sufficient clinical scientific data to evaluate clinical importance of resistance? We're going to look at some shortcuts to answering that, how we measure it, and then we're going to look at some of the things might be done in the future. According to the title, I want to break this down into 2 things. Antimicrobial resistance is an in vitro assessment. BRD management is a clinical assessment. They are not the same. Dr. Engler and his group presented data, some tremendous data showing increase in disease incidence, morbidity, mortality over several years. To me, that suggests a virulence change. It suggests host-pathogen interaction. It does not suggest resistance. There was no antimicrobial data presented with that, was there? How can we relate them? Dr. Apley mentioned Dr. Lubber's report from the laboratory, in vitro assessment. I don't have that here, but if I remember what I read, is like 14% increase in drug resistance, multi-drug resistance from 2009 to 2012. Something like that. Is that right, Dr. Apley? There was no clinical data with that. How do we relate them? Oh, wait a minute. Those are from dead animals. So they had to die of antimicrobial resistance, right? I mean, it had to be that or global warming or nutritionists. They are not the same. How many of you treat Petri dishes? Resistance, it is a categorization, a qualitative interpretation of semi-quantitative response of bacteria in vitro. That's my definition. That's my working definition. We have been in a cycle, a veterinarian in the middle, of taking a sample, submitting it to laboratory. Laboratory does standard operating procedures to give us a result. If they find resistance, it goes on a list. We get the report back. The veterinarian has to interpret and apply that. How's that been working for us? We've been doing that over and over and over and over again and be expecting different results, right? I put this slide in. I actually thought this was a picture of Wayne Searcy, Max Ersick, Gage Friedel, and me in micro class, but last night Dr. Ersick informed me that he recognized this was from the class behind us. So we were a little handicapped. Microscopes come along. We got technology that allow us to do hundreds of samples looking for microbial resistance. And then, of course, we have genetic markers. Now, I got a problem with this genetic thing. I've done genetic markers with seed stock operation, but I have a personal hurdle with this of understanding and using it. And it's not the phylogenetic tree. It's more simple than that. This is for the men in the room. Everybody else, I don't want you to listen. It's just for the men. Men, 50% of our sex chromosomes would suggest we're female. I can't get past that when I'm trying to interpret some of this information. Every bit of this is time and concentration dependent. If you incubate them too short a time or too long a time, you get different answers. Concentrations change. It's all related to the microenvironment of pH, PO2, PCO2, and now neurotransmitters. Well, the CLSI definition of resistant is this, and this to me is the only official definition that there is. When it comes to BRD pathogens, resistant isolates are not inhibited by the usually achievable concentrations of the agent with normal dosage schedules and fall in the range where specific microbial resistance mechanisms are likely and clinical efficacy has not been reliable in treatment studies. You talk to people on the street, your clientele, even some veterinarians. They see the R and they think, everything's going to die. If they see a susceptible, everything's going to live. Totally not true. Where does it say how many will live with that? How many will die? There's nothing in there that's quantitative. It's all qualitative. What are the usually achievable concentrations of an agent? Pretty well defined. Here's one with no variation at all. The normal dosage schedules. We all know what those are, right? That's really well confined. What's reliable in treatment studies mean? That bull pretty much goes on under his own mind, doesn't he? It takes understanding that to influence a change. So here's what led me to my working definition. CLSI has a committee or task force of human beings. They review data from in vitro studies and in vivo studies. Those in vitro data are from standardized SOP procedures for consistency. You get a minimum inhibitory concentration. Some people say it's quantitative. Others say it's semi-quantitative because it's twofold dilution. It's not a continuous variable. We get disc diffusion zone inhibition. We can measure that to the millimeter. Other people say, well, that's quantitative. No, there's semi-quantitative because there's a gradient. It's a little blurry. Takes a little time to read it. Then those two in vitro procedures are associated in scattergrams like this. And on this scattergram, there's MIC and there's zone of diameter of inhibition. There's no clinical data there. It's 2 in vitro tests. The in vivo studies are pharmacokinetic, pharmacodynamic. Pharmacokinetic is a mathematical relationship of concentration and time in the animal. Pharmacodynamics, mathematical relationship of concentration and response, or dose and response. By default, by tradition, with antimicrobial drugs, pharmacodynamics are all produced in vitro. What other drug do we have pharmacodynamics that are established in vitro? Anesthetics determined in vitro? Cardiac medication, blood pressure medication? No, they're not in vitro. I'd like to say that that's the biggest problem of the confusion that we have interpreting in vitro data, the in vivo response. I won't say that. I'd like to, but I won't. Okay? That's all we got until we get clinical studies. The clinical response is usually from a controlled randomized clinical trial. Results may be quantitative, but they certainly are not standardized. Then those data are looked at by that task force and they're placed in a category. Take quantitative or semi-quantitative data and we give it an SI or an R. We qualitate it. All that work, making intricate changes, intricate measurements, and we convert it to a qualitative assessment. The practitioner takes that. They've got to make clinical decisions on, are those qualitative or quantitative decisions? Our clients expect a quantitative decision. What's the quantity they want? 100% success. Can we tell them that with ease? Results in vitro are what they are. Don't make them into something they're not. Few attempts have been made to define quantitative relationships of quantitative responses in vitro with quantitative responses in vivo. The exception to that are the diseases and organisms and drugs where therapeutic drug monitoring is used. Dr. Carricker and others remind us the strength of our data with randomized, controlled, head-to-head clinical trials is far better than anything in vitro or in silico. Yet we have a privilege to work with our target species. We can be at the top of that strength pyramid with properly designed studies. And yet many people find something and the first thing they want to do is run to the lab. Where's that on the pyramid? It's down at the weak end. Some shortcuts to understanding this. In technical materials from pharmaceutical companies on the labels, you'll see things like this. The active ingredient in whatever the product is rapidly absorbed, rapidly and extensively distributed in lung tissue, persists at high levels in the lung for an extended period of time. And you see numbers and an asterisk. What do the numbers represent? References. You can go back and look at references, right? What's the asterisk for? A footnote. How many people look at the footnote? What's the footnote say? I'll give you a clue. Look at the bottom of the page. Clinical relevance has not been determined. Here's another one. Pharmacokinetic, pharmacodynamic characteristics. We see bioavailability, distribution, lung tissue concentration, how long it remains there. There's those numbers and that asterisk again. The numbers, references, asterisk. What's it say? Clinical relevance has not been determined. Then we read clinical study results. They got references. Where's the asterisk? That's because clinical relevance of clinical studies is pretty clinically relevant. Duh! Microbiologic data. 3 pathogens. There is no standard technique for measuring the response with mycoplasma, so it's not on there. MIC values. Look at the asterisk. The correlation between in vitro susceptibility data and clinical effectiveness is not known. If you like playing with words, where it says susceptibility, put resistance. What is the clinical relevance? Unknown. Some more pharmacokinetics. Rapid absorption, bioavailability, et cetera. We got numbers and asterisks. Clinical relevance hasn't been determined. Ask yourself, when you see these statements, are these marketing statements? Are these scientific statements? Are they clinically relevant? They may be all of those things. Interpret it and use it wisely. 10 years ago, Dr. Metley, a physician, was writing about community-acquired pneumonia. Community-acquired pneumonia is very much like BRD except in people. There are some differences. Dr. Metley wrote, little research has been completed on the impact of drug resistance to clinical outcomes. Moreover, among the studies that have been completed, the better designed studies generally have failed to detect an effect of most current levels of antimicrobial drug resistance on clinical outcomes for patients with CAP. Yet practice patterns are shifting in response to the perception that current levels of drug resistance necessitate changes in the treatment patterns. This is unfortunate. Wait a minute. What's unfortunate? Practice patterns are shifting in response to a perception. How many of you select your physician because they practice perception-based medicine? I think it's a great concept. It might catch on. We might even start that. You want to replace that perception with deception. What's the difference other than spelling? Look it up. Replace that word with evidence or with truth. What's that mean to you? This is unfortunate. Why? Because it severely limits one's ability to continue to monitor the effectiveness of available therapies in light of the changing patterns of drug resistance. So are we measuring the best things? 20 inches of snow in Colorado is no big deal. A lot of people think that's just a good start, right? Especially on the ski slopes. In Texas, this is how we measure snow. And it's only because of global warming. Are we talking about measuring the same thing? In this article by Dr. Lamb and the next speaker, Dr. D.L. Steps, is co-author here and helped with this. It's a great study. They looked at treatment regimens in feedlot cattle that died of BRD and the relationship of antimicrobial susceptibility patterns. Notice one of the bottom concluding comments. Factors other than antimicrobial resistance are playing a role in the death of feedlot cattle. What a revelation. Cattle should have responded to antemortem treatments. The isolation of organisms that were susceptible is perplexing. Again, repeat. Factors other than antimicrobial resistance may be influencing the death. My question is this. Why do we expect cattle to respond like petri dishes? Cattle should have responded to antemortem treatments. Why? Who said they had to? Isolation of organisms that were susceptible is perplexing. Why? That's reality. They're not petri dishes. We learned a lot of reasons today and yesterday where that might be possible. Look at the different organisms they found. I think this is interesting. Arcanobacter is back in there, but my question is, if you isolate more than one organism, and co-infection was discussed a little bit, but if you isolate more than one organism, how much blame do you put on each one? What's the fractional contribution of one or the other organism? How do we figure that out? Dr. Taylor, D.L. Step again on this. Existing knowledge does not provide sufficient support for many assertions that have become dogma in discussing BRD. Much more remains to be done. I heard this not too long ago, the statement, to admit you're wrong is to declare you're wiser now than before. Maybe we are making progress. Maybe as a profession we are wiser. So is antimicrobial resistance a reliable indicator of impending disaster? Is it the right sign to look at? There's really kind of a love-hate relationship about the same data. Talk about perception. You can look at the same thing, get different information, different perceptions. It's created a tremendous amount of confusion. There are other confusing signs in life. I like the caution, moving plant. Watch for parked vehicles in a no parking zone. Here's a misleading sign. Is this like resistance? Here's another misleading sign. Notice the license plate, $100 for speeding, $250 for misleading the public. Is this just misleading the public? This sign's not misleading, but it might be misplaced. Is that what's happening with resistance? Or are we being honest with people and telling people what the truth is about resistance? So are we looking at the best signs? It's easy to put things on plates and we've got mechanized systems and that's okay, but I think we have a severe case of identity theft going on. In vitro assessment is not the same as in vivo or clinical assessment. They can't be the same. Virulence and antimicrobial resistance are not the same. Tissue damage, tolerance to organisms, all of those things that were brought up in the Jameson study was referenced earlier by Dr. Mosier, I believe. Excellent information about that. I'm going to go on through that because Dr. Mosier did a great job with that. Find that article, read it. If you want some neurologic gymnastics, take that study and figure out how we could do that with cattle with the 4 main bacterial pathogens and 4 to 6 viral pathogens we got. These data are adapted from data that Dr. Apley published several years ago, and I think Dr. McClary provided the raw data, and I put it in a graph form looking at success and failure. Notice overlaid susceptible breakpoints and resistant breakpoints. And we've got failures and we got successes in every one of those categories. The failures increased towards the resistant group. The successes decreased. But there's successes and there's failures in each of those groups. Those that failed in the group that were susceptible did not fail because of antimicrobial failure. How do we know that? They were susceptible. Why blame the drug? This is another study published by Dr. McClary. I don't know if Dr. McClary is in here right now, but this is so cool. I really like this picture. Notice when we move from susceptible, not susceptible, resistant, the dark bars represent Mannheimia. We see that the probability of success goes down, doesn't it? Not to you, it's like that. Sorry. The clearer open bars represent Pasteurella multasta. What effect did the changing category have with that? It looked like it might even have gone up. There's considerable variance there, and a lot of people might argue and discuss certainly a lot fewer numbers in that group of resistant organisms than there were in the susceptible. What would it take if we designed a study to actually evaluate resistant organisms and to look at failure? It'd take a whole lot more animals. In Dr. Lamb's study, she presented the susceptible, resistant, or total number of organisms like this. Another way to look at that's in a report from either in the literature or the diagnostic lab reports come like this, where there are drugs listed and number and percent resistant over there on the right. If we just get around the elephant in the room, what is the threshold at which we should stop using an antimicrobial drug? There you are, Dr. McClary. Didn't see any answers. Should we only use those to where 0 resistance is reported? If you did that, how many drugs would you be toting around with you? How would that restrict your practice? What is the threshold? How would we determine that? Cost effectiveness. A lot of people want to know, what's the resistance cost us? Again, in community-acquired pneumonia, a study was done. Levels of antimicrobial resistance in these pathogens and multi-drug-resistant strep pneumonia, which is the Mannheimia hemolytica parallel, had minimal impact on cost and clinical outcomes of antimicrobial treatment. Kind of a surprise. There are other studies that show maybe different results. So what can we do in the future? We can't ignore it. We can't hide from it. We need to be courageous like the guy hanging on the horn of the bull. We need to avoid speculation and emotion. Great philosopher John Wayne defined courage as being scared to death but saddling up anyway. Mark Twain defined courage as resistance to fear, mastery of fear, not an absence of fear. I find it interesting to use fear and resistance to define courage. So we can do a lot of things. We can design better studies, epidemiologic studies, to look for the origin of resistance. Is it only in dead animals? How does it know to only go to them? Can we find it in healthy animals? Is it still in recovered, treated animals? Had some young veterinarians one time, they said they had a little feed yard practice, and they said, man, we get a calf doesn't respond. It's due to resistance. We sell it. We get rid of it. I said, really? But can I see your response data? No, we don't keep records. Oh, well, can I see your antibiograms? No, we don't believe in doing those things. How do we sort out anything if that's the way we measure? Evidence-based medicine risk assessment, tremendous tool for communicating results. Survival analysis. In community-acquired pneumonia, if a human patient dies within the first 5 days of receiving appropriate treatment, it's not an antimicrobial failure. They didn't get there in time. They don't blame the drug because they have data. Dr. Jan was talking the other day about the importance of people in treating animals. If they procrastinate on themselves, and we heard about his experience with his daughter-in-law and what the intelligent inheritance is, those people make decisions around animal health. If they can't take care of themselves, how can we expect them to take care of animals? Plus, they vote. We need better studies to relate in vitro and in vivo data and define our expectations. We need to be able to look at, measure virulence. What effect does passage of that organism through the animals? What does that do? What is tolerance to the organism, damage to the tissue, co-infection? What's going on there? And this is my favorite. We need to be working at stopping resistance and reversing it. There can be antimicrobial drugs with new mechanisms of action, and there are a lot of risks associated. This is what we've done over and over again. We get a yes, maybe, I don't know. Einstein defined doing the same thing over and over again and expecting different results. You can fill in the blank, but to me it's like this guy that jumped on the trailer. There is a whole lot of inertia around in vitro data. It's a big moving truck. But if we jump on there like this guy, what kind of view does that guy have of the road down ahead? He can't see what's going on. I recruited the help of a statistician to help define this. One of the simplest studies we could come up with. Logistic regression model with multinomial response potential interactions. We take a look at the clinical outcome, a binomial or a dichotomous response as best as possible. Clinical status, put your score in there, 0 to 4, whatever. The organism will restrict it to 4 bacterial organisms. The probability of isolating, I haven't heard anybody talk about it. What's the probability of isolating an organism if it's really there? What's the probability of missing it? If there's more than one there, what's the probability? I don't know how to factor that in. Then we put the fractional contribution that we still haven't defined. We put in our activity in vitro and our treatment regimens. How many treatment regimens do you want to look at? The comments he had was, how could we have sufficient records? What are the underlying distributions of those variables? And I said, just give me how many animals it would take if I wanted to have a type 1 probability of 0.10. And he kind of got pale. He said, I don't know, thousands? I said, thousands? There's tens of thousands. At the cost of cattle today, how much would that be? If you want to fund this study, get your checkbook, meet me, and we'll see if we can help you spend it. But the other thing he said, it's not even realistic to contemplate a pilot study. Because it would be such a humongous study, you couldn't do just a pilot study. Other considerations. There are drugs that inhibit proteins responsible for inducing mutations. Drugs that inhibit those are one way that we could have new drugs. They don't kill, they just inhibit mutation and development of resistance. Mannheimia require at least one amino acid mutation in 2 places before they can develop resistance. If we could stop that, we could reverse that resistance or stop it. Interference of bacterial virulence and cell-to-cell signaling pathways, especially compelling approach. Look at the host-centric and pathogen-centric differences that are talked about in that Jameson article. This is another one we've got to remember. All resistant phenotypes are not relevant in vitro. In fact, some bacteria that have resistant gene don't express it phenotypically. How do we factor that in? This is cool. Phage therapy, bacteriophage therapy. Bacteriophages are used, I'm learning, in a variety of places in vitro. It's got a very long history of use, usually neglected by English-speaking countries because a lot of this work's going on in Poland, Russia, France, Georgia. Not the state. There's many studies demonstrating that phages are natural and self-amplifying antibacterial drugs that can be used to safely and efficiently treat infections. We ought to look at that in the future. This morning about 4 o'clock, I was thinking about the cattle that have superior genetics, enhanced tolerance, enhanced resistance to infection. What if we could administer a live virus vaccine intranasally with a bacteriophage that went in there and attacked the bacteria in the upper respiratory tract, destroyed their virulence, stopped or reversed resistance, allowed that animal to remain healthy, to grow, become big and strong, and go out and fight for truth, justice, and the American way. About that time I woke up. And a lot of this is going on in vitro, I recognize that. My dream would be if bacteriophages can have teeth, bacteria can have teeth, then by golly, ostriches ought to have teeth. We can take that from the laboratory to the clinic. A lot of work. Recently, I've seen some work with bacteriophages around food. Some work out of Purdue. I want to remind people, some of you, this may be new, the Federal Food, Drug, and Cosmetic Act defines food, and case law in 1983 further defined food. The FDA regards live animals used to raise for food as food legally. It's not that big a jump. We have the technology. So if there are young folks out there looking for a career, I'd like to see some of this in my lifetime. I don't know if I'll live to see it. If I do, I probably won't be able to recognize it. But these are options that's available for us. We live in a tremendous time of opportunity, things that can be done. And I think we need to remember that resistance is what it is. There's a whole lot more scientific information needed to evaluate the clinical relationship of it. We need to read the label, understand those things, and we need to start getting out of the rut we're in. How many of you have heard the definition of a rut? It's a grave with both ends blown out. We've been in this rut for a long time. There are many, many approaches in the future, but one thing I think we must do, and that is to continue prudent use of our professional training. I want to leave you with these words. I don't often quote a senator, but Dr. Simpson, or Mr. Simpson is quoted as saying, if you have integrity, nothing else matters. If you don't have integrity, nothing else matters. With that, I thank you very much.